Thanks, Jim, for the intro, and thanks to Kellogg and to Chris for really a fantastic invitation to this distinguished event. Chris used to work in our group, and I guess he's getting even with me in inviting me to give a talk at 7 a.m. on a Saturday. He knows academics don't function at all, even if slightly at this time in the morning. But actually, I gather also we're quite lucky to have breakfast at all today, because Chris's breakfast wound up in Quebec somewhere. So a couple of days ago, Chris realized that, and I think since then has been frantically shopping for you personally. So there's a real personal touch to that huge buffet out there that we're all enjoying right now. So it really is, it's great. It's a treat to be here and share with you actually something which is relatively new to our team, and I have to say also was something that we arrived at through a couple of, I think, interesting different vectors that I want to spend some time on. So I think we start with the impact of our research, which is making people healthier. That's where I want to start. I'm a biochemist and a nutritional food scientist, but what we really do in our day jobs is try to make a difference at the end of the line, which is the health of the people around us. And people who aren't healthy incur really massive costs to society. So the burden is really substantial, and we're always trying to find a way to improve healthcare. So, how can we reduce the costs of healthcare is something that I think, not very far away from our thinking as we work as researchers. And we know that health really has a huge cost. So in terms globally, the numbers, we see them ponied out in lots of talks. I'm just showing you here 17 million deaths each year worldwide, with enormous consequences of over $1,000 billion estimated in the year 2050, and over $800 billion in the year 2000. So at the global level, these are really substantial figures. It's anticipated that 1 out of 12 individuals actually has diabetes, that 1 out of 2 people actually with diabetes actually don't know they have it, or pre-diabetes, and every 7 seconds it's estimated somebody succumbs to diabetes. So it's really huge, and in terms of the consequences of that, $1 in $9 in healthcare is pushed towards that. So other figures that we have in terms of Canadian costs for health have been articulated by the Organization for Economic Coordination and Development, and Canada falls somewhere in the middle, but around $4,600 is spent on healthcare costs per capita in 2012 numbers in Canadians. That's not as much as the US, but it's a lot higher than a number of the other OECD countries. And when we take a look, I think everyone's seen these graphs, the cost, when you multiply that out by 35 million people, you're up here between 150 and 200 billion dollars. And so these costs continue to escalate, and probably the steepness of this curve is in part because we have an increasingly aging population. So we're seeing more and more degenerative disease. So clearly, this is a huge issue. When we take a look at specific disease entities, CVD accounted for 30% of all deaths in 2009, with a staggering cost to the Canadian economy, what we think is in the order of around $21 billion every year. Similarly, with diabetes, 2.5 million individuals in Canada have been diagnosed with diabetes by 2010. We anticipate another 1.2 million before 2020. And the economic burden of that also massive at $12.2 billion estimated. This graph shows how important lifestyle is. So if you take a look at the top up here, these are health risk factors that include cholesterol levels, glucose levels, and BMI. So if you've got healthy levels of these, then this is your risk. And if you have less healthy, that is, you have a less healthy profile, then your risk is up here versus having more of these where your risk is lower. And then as you look and blend into that model the number of health behaviors, including diet, exercise, and stress, but particularly diet, you can see that as the number increases, out here 3 or 4 of these positive modulators, then your risk actually declines. And so if you have the healthiest levels for all of these health risk markers, plus the best lifestyle in terms of diet, exercise, and stress, your risk for cardiovascular disease is just so much lower than someone who is on the opposite end of the scale. So that extreme is really massive. So food and diet obviously are really important, and functional foods and natural health products are taking, I think, a new level of importance for a variety of reasons. Certainly the aging population I mentioned means that we have more people with chronic disorders and thus a greater requirement for disease management. We really understand more and more about nutrition. That's being pushed through the media, so we're getting more publicity, highlights in nutritional science, and that affects consumer trends and literally draws products that are healthy from the supermarket. So that's important as well. And foods with health benefits do command higher prices. The last 20 to 30 years now in the functional food industry has seen that you can command a better price point. And then, of course, the higher costs of healthcare. So that increasing level of healthcare in Canada, $192 billion in 2010. So all these factors align to make it really important to create a more disciplined way of looking at how we go about studying the economics of nutrition. How can we actually save healthcare costs by improving nutrition? So that spurned this blend or this harmonization between these two disciplines. So these are the classic textbook definitions of nutrition that we all teach our students. And if you look at the most broad interpretation, there's the word economics in there, and I think that's important. Similarly, when you look at economics, you can see that this is really around the broader, the whole discipline of the lifestyle and the food systems that we deal with every day. So we've articulated health economics as a branch of economics concerned with the functioning of healthcare systems and health-affecting behaviors such as diet. And although there's some older studies in this area, I think this has been really reinvigorated, particularly by work led by Irene Lenoir-Wincoup, who's actually present at this meeting and will be presenting today and tomorrow. She and her team from Dannon have really taken this whole concept and re-energized it and reinvented it and created some, I think, very distinctive papers in redefining what nutrition economics is and how it can tell us more about the cost savings that we can articulate by changing diet. So basically, the new definitions really are around health economics supporting nutrition and healthy policy development in an evidence and health benefit-based manner. It speaks to enhancing the understanding of nutrition's impact on health outcomes and its monetary implications, and really critically, I think, assists in developing nutrition recommendations. So consistent with government spending less money and having to deal with a less unwell population, if you will. So it really deals with policy, and that runs all the way out to nutrition and health claims as well. Now, I don't want to get into the technicalities too much, but we import, if you will, a series of systems of examining the data. So there's a cost-benefit analysis, cost-effectiveness analysis, which is more around looking at the long-term sequelae, particularly for health systems. The health effectiveness analysis model is one we use, as well as a cost of illness. And so these are applied in the context of looking at a particular diet shift and then imputing out what the consequences of that will be as far as improvement of health, with emphasis on specific diseases. And that's what I want to spend the rest of the time doing. So we do have some older examples of this. Certainly this is not without some earlier work. For instance, there's been work by Oster and Thompson back in the 90s looking at the Framingham data, and they were actually looking at compared dietary saturated fat reduction versus no reduction, and they were able to deduce how many what the reduced incidence of coronary heart disease would be, and estimated it would be 32,000 events, and then they were able to go the next step and put some monetary numbers around that and actually come up with a value estimate of 1.4 billion to 12.4 billion over 10 years. And I just showcase that range because we're going to see more of that as we consider some of this. It's hard to set the calipers so you have a really accurate estimate of these numbers sometimes. Something that's a little more recent is Dahl et al. So this is an economic simulation model based on secondary data in the US. And here there were three different dietary, shifts that were studied. One was a reduction in calories, one was salt, and one was saturated fat versus no change. And they were able to come up with the numbers that you can see here for each of these. So for calorie reduction, so 100 calories per day, sodium reduction, and 5 grams per day of saturated fat would, with each of these engendering a certain amount of monetary benefit. So those are a couple of examples. In terms of our own work, we started down this path about 7 years ago. We were particularly interested in convincing the Canadian government that it would make a difference if plant sterols were allowed for sale in this country. So at that time, we had a completely naive food system for plant sterols, although other countries had allowed plant sterols for sale. Canada was one of the last to actually adopt it eventually in 2010. So one of the exercises we did under a banner, we had a group of us together. David Jenkins, who's here, was part of our team. It was called CAPSIC, the Cooperative for Advancement of Plant Sterols in Canada. And we ruminated over ways that we could help have these, this bioactive penetrate the Canadian food system. And one of the things we figured was, well, let's see what would happen if we could create an economic valuation of what the potential health benefit to Canadians would be. So we started down this path by taking a look at, okay, we have a naive marketplace. What happens if people start eating plant sterols at 2 grams per day? So our objective was to determine the economic savings with allowing plant sterol consumption, and the design was basically a variation of the traditional cost of illness analysis. And we used 4 stages to do this. We first of all tried to impute a success rate, that is, if these products were available, how many people in the Canadian marketplace would actually step out and buy them. The second thing was, what would be the advantage as far as a concrete biomarker, that is cholesterol, if in those people? The third stage was, if those people had that cholesterol lowering, what would be their reduced prevalence of CHD? And lastly, and probably the most challenging, was how much would that save us? And that's actually pretty hard when you get down to the metrics of trying to do this. So, and of course, there's a range for each of these. And in fact, we set up, it was called a Markov model, where we actually went all the way from an ideal, best case scenario, all the way to the absolute worst. And that's really the hardest part of this modeling, is to try to set the right predictors. So we did that. The first step was success rate, and we went out and tried to figure out, well, how many Canadians would go out and buy plant sterile margarine, plant sterile yogurt, orange juice with plant steriles. It was even available in bread and lemonade and a variety of other things. So we went to the literature and tried to find numbers, and of course the numbers are all over the map. They go from 47 for one instance down to 10%. This was a consumption level similar to a CLA uptake database that we had. So, we realized, well, it's pretty hard to put an exact number on that. With blood cholesterol reduction, we were in a bit better of a zone, because right now we have 200 studies, clinical trials on plant steriles, and we've got a pretty good idea of what the average is, but of course individuals vary hugely, and the studies vary hugely too. So, you can pick almost any number out, but around 10% is where we wound up. And then assumption of the reduction of incidence due to that particular decrease in cholesterol level. That was the next level. And again, the numbers vary. Is it 1% reduction for every 1% lowering of cholesterol? Is it 2? Is it 3? You can find different values. And again, I'm just showing this as an example. It applies to all systems, but particularly for plant steriles, where we did this first amount of work and where I'm just trying to develop the model before we apply it to a couple of other things. And then calculation of the reduction in costs associated with CHD. That is actually a challenge too. We try to base it on national databases, and we try to adjust the monetary values for today's dollars and tomorrow's dollars, not necessarily the data we were able to find, which in this case was from 1998. So we had to roll those numbers forward up to 2007 and beyond to try to get better metrics for the era we were talking about. And then, of course, to try and actually impute what the exact cost categories are for health also is another challenge. So what are the direct and the fixed and variable costs for hospital, for other things? We found in our modeling this to be one of the most challenging aspects. But fortunately, we did have good people to work with. We were working with nutrition economists or agricultural economists in trying to derive these values. So what did we come out with? I don't know if you can really read this, but basically this is the success rate shown here. This is our cholesterol lowering reduction, CHD reduction, and our CHD reduction basically overall with all of these other factors combined. And we have our 4 scenarios across here. And so you can see these numbers vary tremendously from a success rate of 47% as ideal down to actually a success rate as low as 5%. So the numbers were actually, you can see, quite variable. So if we were to take the absolute ideal scenario, we would incur a cost savings of $2,400 million in Canadian dollars. And that's per year, and that is really a massive amount if you think of that kind of impact. If we were to look at optimistic and pessimistic and very pessimistic, we still see large amounts of savings, although they're considerably less. And one of the big challenges with this modeling system right now is to try to predict where in this huge range the numbers will actually fall. And that's what we're attempting to do in the latest iteration of this, is to try to develop a probability curve as to, for the population or subpopulations, at which point in this distribution would you be most likely to find that sweet spot where you would actually see that exact cost reality. So that's one of the things that we're trying to do. These numbers are really massive, and if you put it in some kind of perspective, we're looking at a huge amount For instance, these are titanic proportions, literally. It would take 400 million today to build a Titanic. So we're incurring, even at the pessimistic to optimistic level, a huge amount of money that should save us. Could be spent for so many other important things in society. So that was our first foray, and the plant sterile example was able to generate the framework on which we've now plugged in, and I want to show you actually 3 more examples in the next few minutes. So at the Richardson Center, we've actually gone past plant steriles now, and we're interested, or have been interested, in looking at the Mediterranean diet. Now, this is a very different kind of overlay because plant steriles are either on or off. It's almost like a pharmaceutical. You're either taking them or you're not. Whereas when you're dealing with the Mediterranean diet, you're really dealing with myriad changes all happening at once, all the way from the red wine, to the whole grains, to the olive oil, to the dairy, to the red meat. But we certainly have superior evidence that Mediterranean diet really seems to work. We have the Predimed study now, one of the first hard endpoint studies showing this. So our objective was to try to figure out if we could come up with some reasonable economic health benefits. And I want to take my hat off to Mohammed Abdullah, who presented yesterday, and the student competition is here today, who did the lion's share of the heavy lifting. And also to this person, Jason Jones. It does show that your offspring don't always run the opposite way, which they often do when they see what us academics do for a living and how hard we work and how few of the things we try to get done actually work out. So Jason finished his PhD at Texas A&M and now is an agricultural economist and worked with us on this project. So we applied the same kind of theory as we did with the plant sterile to impute what our med diet success rate would be as step 1. Step 2 would be what would be the CV reduction prediction, and step 2, what would that incur in terms of healthcare cost savings. And so that was our plan. We came out, first of all, we had to figure out what the uptake rate would be. So we used a series of scenarios again. So we did basically as the plant steriles, ideal, optimistic, pessimistic, and we used a uptake rate of between 50 to 5%. And we came out actually with a value, just to skip a lot of steps that I defined for the plant sterile, that we would actually incur a cost savings of between 1.9 million and 2.5 billion in Canada, and 1 to 62.8 billion in the US in terms of annual savings in costs, given a worst case through to a best case scenario. Now again, those numbers are huge in range, and of course when we try to publish these types of data, we get a pushback saying, well, what do I do with something that's that big? And so this is not a perfect science, and we're really now, again, trying to find ways of narrowing the probability to say, well, there's much more likelihood that the ideal or the optimistic scenario will work versus the pessimistic one. And those are the challenges we face ahead. But again, just to put it in perspective, a trip to outer space would cost 200 million. So a lot of us in this room could go to Mars and back for the kinds of bucks that we're saving in terms of these, of making a dietary shift of this dimension. Okay, so this is a Kellogg breakfast, and we're busy eating fiber, and I think it's appropriate to talk about fiber as well in the context of socioeconomic savings and valuation analyses. And fiber obviously has a number of important health attributes. The two themes that I want to dwell on today include functional constipation and irregularity, as well as type 2 diabetes and cardiovascular disease. And this little picture here is supposed to be of this person holding a stool. which was the idea behind the joke, but it's hard to actually see that. How can you talk about constipation without at least trying to make some kind of joke? And Chris, no offense, but fiber is, of course, as we know, extremely important. So the dietary fiber valuation model is not dissimilar for plant sterols, not dissimilar for the med. It's a three-step model. I've shown it here in this context in that, again, the fiber success rate, if you're trying to induce some kind of dietary change, how good will you be at enabling that? What will be the disease reduction that follows from that? And then what is the cost consequence, the cost reduction for the healthcare system? So the objective was to systematically assess the economic impact of increasing total fiber intake on annual healthcare costs associated with A, constipation, and B, type 2 diabetes and CBD. And we clustered those in two separate activities, and we're actually hoping to disseminate that information shortly along those lines too. So constipation is actually extremely prevalent. 27% of Western countries experiences this. 1 out of 4 Canadians. In Canada, approximately 1 million physician visits occur each year around constipation, and it's healthcare costs of around $7,500 per patient. And we spend about $100 million annually on laxatives. That's a huge amount when you think. So it's probably one of those quiet kinds of disorders that you don't hear about so much. But notwithstanding, we certainly know that clinical management of constipation starts with increasing fiber. And we think around 25 grams of combination of soluble and insoluble is the way to go. So research has established the beneficial impact of higher fiber intakes, and basically we relied largely on a study of 62,000 women in the Nurses' Health Study, which showed a 36% lower prevalence of constipation with the highest quintile of total dietary fiber intake. That was 20 grams per day versus the lowest intake of 7. And the key number that we used for our analysis was this one, which was 1.8% reduction in constipation for each 1 gram increase in fiber intake. So we used that as the basis for a paper that we're hoping we can see being accepted, which was the economic benefits of increased fiber in relation to functional constipation. And this is the graph I'll just show you. So what we did was we took our current fiber intakes for Canadians, which are basically 19 grams per day in men, 15 in women, and we set the Institute of Medicine targets of 38 for males and 25 for women as our best case scenarios. And then we also took a look at a structured, graded, stepwise incremental increase of fiber, and we're also interested in a per gram intake of fiber and what that would do too. So in our model, we actually we calculated out that each per gram, our constipation reduction per gram of fiber intake would be 1.8 and for men and women based on that analysis, and the population expected to respond to the fiber intake we assumed to be 85. And then when we ran our modeling, if fiber intakes were to increase to levels corresponding to the IOM medicines at adequate intake for males and females, that up to 45.6 million in healthcare costs could be saved annually as a best case scenario. And if in the lowest case scenario, where only 5% of the population increased their fiber intake, the cost saving would still amount to $2 million. And with each 1 gram per day increase, we would see a result in total annual healthcare cost saving of between $0.2 and $3.5 million. So these are substantial amounts. When you break that out into the costings associated with physicians, hospitals, other serious hospitalization, and drugs, again, you see a gradation based on either universal, that is 100% uptake, versus all the way down to very pessimistic 5%. And again, our challenge now is to try to figure out which of these scenarios is the ideal one. So the last case I want to leave you with, reasonably briefly, but not at all the least significant, is the impact of dietary fiber on costs associated with type 2 diabetes and cardiovascular disease in Canada. So we certainly have lots of data that associate dietary fiber intakes with prevalence of type 2 diabetes and cardiovascular disease. In our extensive review that we conducted recently, we landed on data which we decided to use to take forward into our modeling for both of these, for diabetes and for CHD, and those are shown here. So the Anderson and Connolly review of 2007, which was a very extensive meta-analysis of 5 cohorts involving almost 250,000 individuals, showed 19% lower risk of diabetes among individuals in the highest quintile of diet fiber intake. And for our CBD, we used a meta-analysis of 7 cohorts. This was Anderson 2004, again showing reduced risk in the highest level of dietary fiber category of 29%. So again, this is similar to the constipation analysis, but we took the existing intake of Canadians and then we applied the Institute of Medicine ideal scenario and then used this 1.7% reduction in type 2 diabetes for each gram of fiber as our modeling basis here. And for CBD, we used 1.3 based on these meta-analyses and then calculated out the numbers. So this is what we came up with. Really, in a nutshell, substantial healthcare cost savings when we model these data, which we feel are fairly reliable, into our direct and indirect healthcare cost budget scenarios. So if fiber intakes were increased to levels that correspond to the IOM's adequate intake, then non-trivial healthcare savings would result of between 57 to 1,146 million in type 2 diabetes costs and 76.8 to 1,538 million in CVD costs that would accrue as a consequence of this. So the upper range is definitely per year, should be something that healthcare systems take a careful look at. And when we looked at this on a per gram day basis, each gram per day increase of fiber was imputed to result in a savings of between 1.8 to 35.8 million dollars for type 2 diabetes and 5.4 to 108.8 million for CBD. So again, pretty substantial. This is the valuation just shown graphically. And again, I just demonstrate this because the ideal or universal scenario really does step well away from the other numbers, as we saw with the plant sterile modeling. The range is huge, and we need to figure out where the most highly probable point is. Where is the greatest probability of a real saving for type 2 diabetes? And for CVD, it's the same issue, although it's a little bit more linear. But the total maximum amount here really is staggering. And if you take a look at the cost of a mansion in California, even at $100 million, wow, a lot of us could do pretty well if we were able to translate that into real money we could keep at home and go retire in the land of the hot sun and ever decreasing amounts, I guess, of available water. So lastly, this whole the whole issue of health economics, I think, requires a synergy between a number of stakeholders. So the scientists in this collective provide the health and economic-based evidence. We need regulators to take the numbers and interpret them and set clear guidelines for healthy eating and lifestyle. And then I think the food industry also has a responsibility to create products that embody these kinds of bioactives that can confer health and produce the healthcare cost consequences. So as a final remark and conclusion, I really do think these model estimates, despite having their limitations and the width of the numbers, which is apparent, they can shed light on economic valuation of nutrition and functional foods of Canada as well as around the world. The importance of communicating the economic benefits of easily achievable dietary change to the general public and stakeholders alike needs to be featured and highlighted from this sort of analysis. And I think it sets the stage for public policy strategies that advocate healthy eating behavioral change to address and manage challenges of Canada's healthcare and societal systems. So I just want to also acknowledge all of good folks who helped out not only with this presentation, but who've really helped us with the modeling, and particularly Dr. Irene Lenoir-Wincoop, who is presenting at this conference today and at the workshop tomorrow. Thanks to you all for your attention so crisply early on a Saturday morning. Thank you very much.